Welcome to the American College of Surgeons Bulletin Brief from the front lines, Surgeons' Voices. With me today is Dr. Carla Pugh. Dr. Pugh is a professor of surgery and director of the Technology-Enabled Clinical Improvement Lab at Stanford University, which I like. It's TECI, T-E-C-I, Technology-Enabled Clinical Improvement. Welcome, Dr. Pugh.
Thank you so much, Dr. Wexner, for having me on. This is very exciting. I'm looking forward to our conversation.
Well, great to have you with us. You know, the word improvement goes along with the quality improvement programs of the American College of Surgeons, and you've been a great collaborator with the American College of Surgeons, with Dr. Coe and the Division of Research and Optimal Patient Outcomes, with Dr. Sachdeva and the Division of Education. You've really put a lot of great effort into college programs, and we're trying to improve outcomes, and you're trying to improve outcomes. So I wanted to chat with you a little bit today about how information is used to improve outcomes. And I'll leave that rather open-ended, so you can talk a little bit about how your research got going and some of the things you've accomplished.
My research fits squarely in the area of simulation, at least as a method. I think that what we've tried to do is actually to add new data in the simulation world. And the new data is actually combining simulation technology with wearable technology. And so in 2019, at the Clinical Congress, we had practicing clinicians put on wearable technologies while they were asked to run a loop of pig intestines looking for enterotomy and then have them repair it. And when you step back and look at that focus, wearable technologies and practicing clinicians, that gives us information regarding the decision-making and operative planning and technical approach of practicing clinicians so that we can quantify it and develop a research process that would help us to map those decisions and then share them efficiently using artificial intelligence and other data analysis techniques. And that's what we really want to do. We want to be able to digitize mastery and share it amongst the masters, obviously realizing that that database will also be helpful for fellows and residents and other trainees.
Certainly sounds like a big advancement over watching people operate or watching videos of people operate. So perhaps I might first address the wearable technology. What are these wearables that the surgeon would be wearing during execution of the steps that are subsequently assessed?
Wearable technologies, the first one that we're really excited about is motion technology. Right now, the technology is a commercially based technology that's wired, and our group has done work to miniaturize this technology and make it wireless so that it can fit underneath our gloves. That's the end goal, something that fits within our workflow as surgeons, and it's streamlined. But the fun thing is synchronizing that technology. The motion tracking technology can be synchronized with video, and it actually helps us to streamline the video review process by looking at the motion output. That's sort of one connection. The other wearable technology that we piloted was actually a wearable EEG signal, and that was really interesting to look and see when surgical decision-making and planning is taking place. And what we thought would be really interesting and relating to that data really relates to team communication. I actually have worn the technology myself, the wearable EEG in the operating room. And the interesting parts of the operation where you're really focusing on anatomy or you are instructing a resident through an important part of the dissection, it's a clear visual communication to the team members in the room. This is probably not the time when you want the circulator to leave the room. because that's the, that's when you need them to hear you if you need another instrument or, something else that would facilitate that dissection and that focus. So the two main ones, wearable motion tracking and wearable EEGs. The other ones are video and audio technology, which are already exist in many ORs.
Thanks very much. Have you been able to analyze the data to find any discrimination amongst different levels of trainees or between trainees and practicing surgeons or junior surgeons, senior surgeons, or any permutation of comparison?
No, I love that question. And so our prior work, we did do that validation type of comparison, looking to see whether the technology can see differences between residents and clinicians. We did that as pilot work with Department of Defense grant before the college meeting. Because we knew the technology could tell the difference between, residents and faculty, practicing clinicians, what we wanted in the college meeting that took place in 2019 was to only collect data from practicing clinicians, because then that's a higher level of discrimination. You've got everybody who has already met competency, minimum competency, and now we're looking at various levels of mastery during each step of the procedure and how people do it differently and what are those metrics. And yes, we have found a difference. We haven't published yet. We are it's hot off the press, and there's a lot of details to look at. But we do have the answer. I can tell you at a high level, even with a simple task of running the bowel, looking for enterotomies and then repairing them. There are multiple different ways to even run the bowel. And most of those ways there were people who missed enterotomies. Actually, out of the 250 people who volunteered, about 60 people missed enterotomies. And so it's hard to tell that because we didn't have eye tracking technology. But that is another one that another wearable technology that could be added. But there were a higher number than we expected that missed enterotomies. After that, those who found the enterotomies and began to repair, people do make different decisions along the way. Some of those decisions have a higher leak rate percentage than others. What was interesting is that every step along the way, different technical approaches varied in their risk, and there was a significant difference. If you chose one approach, significantly lower leak rate than another approach, but those who were doing approaches that had higher leak rate, there were still people who were successful. So that was really what piqued our curiosity. If you're taking this risky path or this, path that has a higher percentage of a poor outcome, those who do well in that arena, what is it? And it turns out that it's not just technical skills. In fact, it's more of what we are calling a technical decision, really relating to perception. When you see a hole this big or an injury or something that needs to be repaired, we automatically have in our mind how many sutures, for those who do interrupted, if they're going to do interrupted, how close should those stitches be? How many should you put in? We usually never count. We just start repairing. But what we did notice was that people who had just a millimeter wider space between their stitches, they had a higher leak rate. And we don't measure those things. It seems so, such a minor difference, but that was the significant difference between those who went down the interrupted path, as well as putting anchoring sutures. It's things we talk about, things we're like, oh, that's attending preference. Well, I think what we're going to learn is that there are some things that will put you at a higher risk. And our dream is to just have that information flowing. When you're in the OR and sometimes we're forced to make certain decisions because the anatomy that's presented to us. And so I think that but then other decisions we make is just because that's the way we do it. And so I think that's what we're really after, is getting data from practicing clinicians. How do they do this? Where do they make detours in their technical decisions and approach? And which one of those decisions really matter and which ones don't? That's what we're after.
Fascinating. Have you conveyed the results of individual performance to the surgeons who were assessed?
Not yet, because we had to, that is the sort of little lag time. The hardware and the technology is there, but when you're collecting the data for the very first time, you then have to go and figure out which AI algorithms and mathematical algorithms give you the information that you want. So that's our goal this coming year, is that we now will have the algorithms that give us the desired information linked to the wearable technology so that we can get real-time output. So that's part two.
Yeah, because certainly behavior modification during the behavior might ultimately give the most improvement versus downloading the information at a subsequent time to improve performance the next time the same task is performed.
Yeah, the real-time information is what we're shooting for. We can't give the information if we don't have a database. So that's the real goal, is to get practicing clinicians to partner and be willing to share their information. I think the reality is that, that's the next hurdle in terms of getting this into the OR and looking at real patients instead of in a simulated environment. And then being able to protect our right to share the information without fear of litigation.
Yeah.
That is the hurdle. And there are a lot of groups working on it. So it's not just the Techie Center in our lab working on this. And so there's the Institute of Surgical Excellence, a bunch of other surgical groups. And we hope, obviously, to partner with the college efforts in terms of allowing information exchange that would improve outcomes, as opposed to, having a patient want to use that information against us.
Given those complexities and those formidable hurdles, I certainly will not push you on a timeline anyway. So instead, let me ask you about a different area that many of our over 85,000 fellows are not general surgeons or even sort of abdominal like me, colorectal surgeons, but orthopedists and plastic surgeons and ophthalmologists and the like. So have you gone and forayed into any of these other fields with the simulation monitoring devices for orthopedics, plastics, anyone else, any of their procedures?
Yes, we have, and it's been very exciting to see consistent results. We have publications, so I'll definitely share those. But we've done this with cardiothoracic surgeons, and again, one of the things that comes up that's been consistent across the procedures is it's the more ambidextrous you are, the more efficient. We've always sort of known that as surgeons in our observation, but how do you just tell a trainee or tell someone, use your left hand more? I mean, they need a number, they need to see what's really happening. And so we're actually able to quantify that and show that to them. And we have publications in cardiothoracic surgery. We also have publications in orthopedics relating to use of this technology, even just for cast removal, bedside procedures, as well as complex operative procedures. We also have it in plastic surgery with microsurgical vascular anastomosis, which obviously is applicable to vascular surgery as well. We've done some with OBGYN, and wow, there's a long list. It's been over the past 7 years, we have partnered with any specialty who's been interested. It's been amazing to see the consistency when you focus on practicing clinicians, that then you start to see what we are calling attendant preference or, idiosyncratic ways of doing things. We're actually more alike than we think we are. It's just that we talk differently about it. Our verbal explanation is different. And so I think that's one opportunity when you have digital data. It says it the same way every single time. It's based on your motion and maybe not so much, that I use a right angle and I use a tonsil clamp, but you're still dissecting this same vessel. and how much effort do you need? And maybe that will give us some information about the efficiency of certain instruments that we use for dissection. But we are more alike than we think we are. And I think that will also help our profession.
Fascinating. I congratulate you upon the entire body of work. Really impressive, and I'm sure it's going to take us logarithmically forward in our ability to know how to operate and to try and standardize conferring optimal outcomes, or at least best outcomes on patients. Any final comments about next steps and future direction other than those you've already mentioned?
Yes, I do. And I think it's one just in terms of the landscape, and that a number of people worry that having this type of data would take away the art of surgery. And I think it's nothing is further from the truth. What we're realizing is that there are multiple ways of doing things, and you still get good outcomes. And so it actually will be confirmatory. I think the other part is people fear the data, that it will ultimately be used against us. I think that we should be proactive. The reality is that many of the devices that we use in surgery, the next generation of them will collect data. And we should be the ones that have already said what data is useful, and then industry will fall suit behind us, as opposed to them capturing metrics and then putting them out there and then having various groups say what's a good surgeon when they don't really understand the data. This is something that surgeons should lead, not industry.
Absolutely, and I'm proud that the American College of Surgeons is at the epicenter of such efforts across many, many facets of quality improvement, with the almost 30 quality improvement programs we have, the data that the college collects and helps analyze, which, as we've seen in many publications, outperforms the other commercial and for-profit databases. So thanks again for your time, Dr. Pugh. I really appreciate it. I've learned a lot. I can't wait to read the paper about the results of the 2019 Clinical Congress.
Wonderful. Thank you so much for having me.